Hi, I'm Desiree Chappell. Welcome to Top Med Talk. It's Tuesday and it's time for my Roundtable. The Roundtable is a chance to sit down with a multidisciplinary group to have discussion about perioperative care and improving the quality of what we do every day.
Top Med Talk.
I'm here with Monty Mythen, Editor-in-Chief. Hello, Monty. How are you?
I'm Desiree. I'm good, thank you.
Great. We have Dr. Frances Chung. She is an anesthesiologist and on the board of directors. She's a professor of the Department of Anesthesiology and Pain Medicine at the University Health Network and University of Toronto. And she is also Res Med Chair of Anesthesiology, Sleep Medicine at the University Health Network. We also have Pfeifer, who is the Vice President of SPOCIAT this year. He's an internal medicine physician at the Medical College of Wisconsin. Thank you both for sitting down and joining us on Top Med Talk.
Thank you.
Yeah. Frances, stop bang is one of your, is kind of what you're known for. And that's one of those things that I think a lot of people are really putting into practice. And I love some of the things that you had to say about, really utilizing that in practice. So can you tell us a little bit more about stop bang and your experience with that and utilization of it?
So the stop bang is a sleep apnea questionnaire, and I actually developed it because what happens with obstructive sleep apnea patient, they do have complication. I do have a patient that have complication, and I said to myself, okay, how can I identify patients that have sleep apnea that I don't know about and coming to the pre-op clinic, because it can result in death or near death, mortality and morbidity. So I developed this tool a few years ago now, and it published in 2008 in Anesthesiology's 2009. And I have put this on the website, www.stopbang.ca. So stopbang.ca, Canada, because somebody copied it as stopbang.com, exactly the same, and they make money on it, asking people to fill in questionnaire. So anyway, it has been widely adopted, not only in the pre-op area, but by the sleep physician, cardiologist, dentists, ENT, and some family doctors. So actually, I think the good thing about it, it can identify high-risk patients. So if the score is 0 to 2, and actually it means that the patient has very little risk of sleep apnea. So it's just 8 questions, very simple, like snoring, tiredness, fatigue, high blood pressure, BMI, neck circumference, gender, and all these. So very simple. I didn't use a computerized system because the 8 questions are not weighted equally. And I know that it doesn't weigh equally, but I want to be simple and stupid. And it can be used without computer.
Yeah.
So that is why I purposely did not weight it. And it's easy to use, and that's why it's wide adoption. Yeah.
So
Monty.
We've done a few pieces before on stop bang from some OSA experts and enthusiasts, put it that way, for identifying OSA. And Kurt, you raised it in your lecture as well, using it as a screening tool. Could you expand on that for a second?
Yes, and it's, as Frances pointed out, it's, keeping it simple, you might say, well, then that's going to mean that it's not going to be perfect, but one of the fallacies in perioperative medicine is that there's some perfect tool, some universal thing that's going to work for everybody all the time. And that's not really what any of our screening, the purpose should be. It's try to increase the chances that we're going to identify those patients at higher risk, because those are the ones that if we focus time and energy on, then we can potentially do an intervention to improve their risk. And that's why I think so much of the follow-up work to what Frances has done with stop bang of then identifying, well, stop bang of 5 or higher, they're at higher risk, but then who's really even at the higher end in that group? So the stop bang of 6, indicating that's an even higher risk patient, or a stop bang that's elevated along with an elevated bicarb, that those are the patients you really need to worry about. And for instance, if they're having a non-urgent surgery, you would actually consider holding up that surgery to pursue further evaluation by sleep medicine before you go ahead. And so we're not stopping a ton of surgeries. We're only stopping them in the patients who are at the highest risk based on that screening. And then for all the others where the screening identifies them as potentially at risk, although you might say, well, you don't do anything. We don't do anything in the pre-op setting because there's not much we can do to make a person that much healthier in this regard. But what we can do is make sure that we've got the right resources and plans in place perioperatively to try and keep them out of trouble. And as I had pointed out in my talk, it's actually made it somewhat frustrating in modern day era to see what is the risk related to sleep apnea, because almost all hospitals have adopted policies and practices that are already mitigating a lot of that risk.
Yeah.
And so when you go back and try to see if an intervention you're doing is helping, you're already doing so many things that if you don't see a response, it's not necessarily because that doesn't work. It's because without knowing it, you're already doing a ton that's focused on that screening effort.
Yeah.
So I think another thing was raised was the question about opioid sensitivity and obstructive sleep apnea. Either of you, where do we stand on that at the moment? I was a little bit pleasantly surprised.
Actually, the opioid sensitivity is actually, there are a number of articles on this. The first, it comes from the animal models in which they say the opioids actually in the rat is the rats who have obstructive sleep apnea. They actually are more sensitive. And then the Montreal group actually did it in the children, and they have a few studies coming out in which the children who have sleep apnea and who come for tonsillectomy, they actually look at these children and they find that those who have obstructive sleep apnea, they're much more sensitive to the fentanyl, and the dosage of fentanyl is reduced by half. Mm-hmm. However, in the adult, it's less. Actually, the evidence is a little bit controversial. So there are some studies that said it's opioid sensitivity and some say no. So I would say for myself, because I am always worried that I will have a lawsuit which kills my career, I do say it's opioid sensitive. So if I have an outpatient or inpatient, I always tell them, take Tylenol, acetaminophen, and say, and then use the opioid. If they go home with opioid, I ask them to cut them in half. Just you half a dose because you may be opioid sensitive, and I ask them to take half and then take the other half pill if they still have pain.
Isn't that what we're trying to do for everyone now, though?
Yeah, that's what we are trying to do. Correct.
Let's just do the right thing for everyone.
Right.
For everyone.
Yes. Right. Yeah. Perfect.
Yeah.
Perfect.
Francis, one of the things that you talked about in your presentation was the OSA registry, and you showed something that was very powerful, some pictures of children and young people that are dying from post-op complications or post-op, I guess, opioid issues and obstructive sleep apnea. Can you tell us a little bit more about that?
So the Sleep Apnea Registry is an effort by the Society of Anesthesia and Sleep Medicine and also Anesthesia Quality Institute, which is from ASA. Mm-hmm. It's a combined effort, and we actually collect the data from 2014 to 2016 in which we ask people to submit their cases in which they have adults, cases that actually have death or near death or critical events during those years. So we actually have 77 cases submitted, and out of those, 3 people identified these cases and look at them, and we actually identified 75 cases related to OSA, and 2 cases we excluded. Okay. And essentially, we find that these patients are relatively young, 52 years old, more are male patient under GA, inpatient, 90% are under general anesthesia. And actually, if they are monitored, they have 6 times more likely to have just critical event and they are rescued. But if they are not monitored, they are more likely to die. So essentially, if the event happened in PACU, in step-down unit, ICU, they survive. But if it happened in the ward or at home, they're mostly likely to die. So that's what we actually find.
Wow, yeah. A lot came out of that. The other thing that I've found interesting, we talk a lot about like morphine equivalents, and obviously it's dose-related, opioid-induced respiratory depression, things like that. But there was also, everyone that you showed that had died, most of them had, it was PCA,
yes.
Using PCA, and you think, PCA, that's more controlled, but actually, those are the people that died. Can you talk a little bit, either Kurt? I mean, what do you think about that?
Yeah, and so with PCA, of course, there's it's are you giving basal? Are you giving bolus? Even with bolus alone, there is a danger, and it's why some people, I think, are opposed to it. But I think in those patients, they were going to be at risk from any kind of opioid. And that's the problem, is that actually it's young people and people that get labeled as low risk that sometimes are the ones who succumb to these things because people just let their guard down. And that's why it's so important to utilize protocols like Monty said, that let's try to do the right thing for everybody. To be, these are dangerous drugs that we shouldn't be giving to people without really being on top of watching for their symptoms. And the thing I think that also, even though those patients are dying on PCAs, is the number of patients who are going to go home and be at risk. Because with sleep apnea, another thing that's a struggle is that we know from studies done by Francis and others that your increase in your sleep disordered breathing from surgery, it's not like it's done after post-op day one. It persists for days, and they're going to be home at that time. And so that's why we also have to be so thoughtful at the discharge. What are we sending you home with? What is your plan when you go home? And even in patients where we know they have sleep apnea, there are some surgeries where they will not be able to use it. So I see a lot of patients having eye procedures where they say, no, they can't have their PAP for 2 weeks. Well, then we have to have a good plan for what are you going to do when you're at home to try and mitigate the risk.
I want to share a story in which it's not a story, it's a true story. It's a 44-year-old veteran who has a young wife and 2 young kids under 5, and he had back surgery. And then what happened is he is on CPAP, diagnosed OSA, and after first day, second day, he okay, sent home, but the orthopedic surgeon gave him opioid and also some sedative, some benzodiazepine. He actually died at home. The CPAP machine was off on the floor because usually these patients wake up in the middle of the night, 4 or 5 o'clock when they have REM sleep. And actually it's the most difficult time with the sympathetic activation. He took off the CPAP. He died. Right? So it's a very sad story. And it's a true story.
Yeah, that is very sad.
So we've covered a lot on Top Med Talk about the so-called opioid crisis and the issue of, in different countries, how many opioid meds people have traditionally gone home with. What's the state of play? Well, let's look back 2 years ago. What was it like where you worked 2 years ago?
So there definitely was a lot less awareness. There was a sense that it was just routine practice for virtually any kind of surgery where you're going to be sending them home with some type of opioid pain medication, because as Linda Russell in an earlier session at the Preoperative Summit was talking about, pain is the 5th vital sign. And unfortunately, that drove some unintended consequences, which is that I'm not having anybody give me a bad review because I didn't attend to their pain. And now, finally, with the opioid crisis really being recognized, we see that surgical programs really are being thoughtful up front, both about establishing appropriate expectations for pain. So, what should you expect? And that knowing that there's not going to be zero pain, and that we're going to do things short of using these powerful drugs, everything we can, and use those only as a last resort, only for this short period of time, and then that's it. So that we don't have these things being perpetuated. Also, it's with the data that's come out just showing how many patients end up developing a problem with the opioids afterwards.
We had a great multimodal pain session before the lunch break, and this is one of those disconnects we get. We were touching on it a little bit when we sat down. It seems that a couple of years ago it was commonplace for people to go home with hundreds of opioid tablets. Is that fair comment? And I presume they're not free.
Right.
Okay. But repeatedly in discussions in the USA about using IV acetaminophen as a rescue analgesic, the reason you can't do it is because it's very expensive. I don't understand how you can send them home with a sack full of opioids, but you can't afford a bottle of IV acetaminophen.
It's about where's the cost going.
Siloed. The cost centers are siloed.
The hospital doesn't want the cost, but if they send you home with a script for
they're
the opioids,
not paying for that.
Yes.
I've got it.
Yeah.
No. Right. What happens in Canada?
Sorry, we're screwed up in America.
No.
Are you kidding?
That's not what I'm saying. We've all got our own screw-ups.
we have our own issues.
Well, Canada, we actually is the same as USA, but now our government with Trudeau, they are trying to develop to cover all medication, but that is in the work at the present. Yeah.
But is everyone trying to get a lid on the amount you go home with? That seems to be
it is trying to. And actually now, patients in the pre-op clinic are patients complaining, I only have 5 days of opioids. They come back for the other knee and hip, and they are so scared. He said, the doctor only give me 5 days, and I have a lot of pain. Nobody is willing to give me meds, and I still have pain.
Yeah.
And he said, make sure this time I have enough meds. So they swing opposite.
But surely you can have the meds if it's still hurting and you need them. It's just what you don't need. You don't need them in your bathroom cabinet,
right? They've made it more difficult to do that once you call in, and you have to have a written script. And I mean, there are challenges that are associated with that too.
It's always a pendulum effect.
It absolutely.
And so we are swinging back the other way now, where surgeons are saying, "No, I'm not," because it's dangerous.
Yep.
And as always, you can't be reflexive or just you have to be thoughtful. And so, with those patients where clearly you can tell there's a reason that they need more pain medication, you have to work with them.
Yeah.
But as to Monty's point, you don't send them home with a script that has 3 digits for the dispense amount. That's a bad idea.
Renew. Yeah, it's so reactive. We are also reactive. But I think that some of the multimodal pain management schematics that are coming out, and that it's a huge patient education. I mean, at our facility where I used to work, we did an enhanced recovery program, and what we learned early on is that we we're not doing a good enough job educating the patient on how to take their medication at home. So they were fine that they, low dose narcotic. We weren't going to send a ton of narcotics home, but what no one really taught them was how do I actually do this multimodal, doing ibuprofen and Tylenol and do that back and forth, and what is my schedule for that? People have a very difficult time working out their pain management schematic at home, rotating ibuprofen and acetaminophen, and what is my schedule for that, and what if I get off schedule, and what if I have break, So we found early on that we needed to spend a lot more time on that educational piece. And so that was a learning experience for us. But I think that as we start to go down that road. Now, one thing that you said yesterday, too, was and this is kind of going back to our earlier conversation, though, was gabapentin and how that affected, in addition to the opioids, how that can affect.
So gabapentin, we actually in our hospital, we stopped using gabapentin for our hip and knee patients almost 8 years ago. And Mayo Clinic Toby Weingarten has done a lot of work on this area. And he actually found the gabapentin, even 300 milligram dose.
I'll say low dose is what you heard to say.
300, 600, 900. He says it's not dose related. And actually, it's 6 times more likely to have respiratory depressions in those having gabapentin and opioid after surgery. And also that wasn't obstructive sleep apnea patients.
No, that was just general population.
In general, yeah. And also, there is another study, it's a population study, retrospectively looking at data, and these are patients not having surgery, but they are patients having chronic pain. And if they are on opioid and they take gabapentin, their death rate is 6 times higher.
Oh my gosh. Gabapentin's a huge piece of the multimodal thing right now.
It is, but opioids already have a narrow therapeutic profile, but gabapentin especially, it is exquisitely sensitive to renal function. Yeah. And we know that's getting bumped all over the place in the perioperative setting. So a common theme that we encounter in postoperative co-management is coming by and seeing that the patient is lethargic and looking through their meds, and the first one that we'll see ring up, there's gabapentin, and we'll often hear, but all they got was 300 mil. It doesn't matter.
And their renal fighting, like you said.
Their creatinine's 1. They're also 85 years old and weigh 40 kilos, so that's too much.
Yeah. Oh, that's interesting.
Can I, because the clock is against us, if I could just pick off 2 quickies in your lecture, Kurt, the beard test and the upper lip bite test, to predict difficult intubations.
What was the first one?
Beard.
Beard.
The beard.
Beard.
Sorry, beard.
That was the Hagrid sign. That was my made-up thing. Yes.
Is it if your beard's bigger than your head?
Yeah, if your beard's bigger than your head and a bird can nest in it, then you're probably hard to ventilate. So it just raises the point. There are a number of things that can make you. So especially when I work with my internal medicine colleagues, they often aren't as aware of difficulties with ventilation and intubation because they don't have to deal with it. With ventilation in particular, it's recognizing that some of these patients will be hard to get a seal on, so that a beard can be in particular one of those things. And actually, you'll see it where some patients who, again from Milwaukee with the Harley riders, guys with big bushy beards, you sometimes have to talk to them and say, you're at more risk for us being able to manage your airway, and you recommend, well, the best thing we could do would be to shave that off, although most patients would be like,
I've been working on this thing for a while.
I'd rather lose my leg.
Yeah.
We can manage that. The other one which prompted a lot of people in the room joining in was the upper lip bite test. Yeah,
so of all the different, if you can bite your lower teeth up over the upper vermilion border of your lip.
It doesn't matter. You're not your tongue touching your nose, but your mouth.
No.
And I looked around the room and there's a whole load of
everybody was doing it.
And they're kind of then thinking, the people are watching it.
It's just like when you actually examine a patient and ask him to do it, you find yourself unconsciously doing it, like feeding a baby.
It's not a great radio moment, this, but we'll see if we can get a photograph.
Right. So that's the test that actually of all the different maneuvers for assessing difficulty intubating somebody actually has the highest positive likelihood ratio, which I would argue you want tools that are best at identifying here's somebody who truly is likely to be high risk, not here's something that will rule it out, because nothing is very effective at that.
Yeah. And to close, if I may, Desiree,
please.
Postoperative pulmonary complications are common.
Yeah.
They're serious. There's an ongoing debate as to whether there's much more common than MINS, which we keep talking about, and have a greater burden.
Right.
Yeah.
And you talked about the eye cough intervention, which I think is incentive spirometry, coughing, oral care, understanding, get up and get the head of the bed up so people can look up eye cough if they're not doing it already.
Right.
Is that evidence-based or eminence-based?
So they're evidence-based. There are a number of institutions that have employed this and specifically measured postoperative pulmonary complications and seen a significant drop in it. And so in a lot of ways, it's like other protocolized things like enhanced recovery systems where you have a plan of attack. This is what you're doing for everyone, and especially something like this, which these are small interventions with very minimal risk and can have major benefit.
So I say brush your teeth.
Yeah, exactly. Go down the list again. Incentive spirometry beforehand, so get a blowy thing from your doctor, is that right? Get coughing beforehand, so deep breathing and coughing. Mm-hmm. Yeah. Look after your teeth, which is a good idea in life anyway.
Yeah.
Understanding, that means explaining to people what to do, is that right?
So explaining both what their risk is. So it's putting the fear of surgery into them so that they understand this is why you should do these things. Yeah. Then understand here's what we want you to do and how important it is. And that's where if you can have other family around to be advocates for that, to teach them as well, that's great.
And then the big G. Get up.
Get up and get moving.
Get on those pins. So even if you can sit on the edge of the bed, the evidence from decades is you're already breathing much better. If you can stand up, you're breathing a lot better. And even if you walk on the spot, you're really nailing it then.
Right. And now the newer data on Fitbits showing that.
Yeah.
Get them moving.
Francis, big thumbs up on that one. Get them up, get them going.
Yes.
So tell the patients and tell their loved ones that irrespective of what the doctors and nurses say, pester them to get you out of bed unless it's really not good for you.
Yeah.
And if you can't get out of bed, put the head of the bed up.
Right.
Yeah, that's good.
Eye cough.
I love it.
Saul's gone now, but he was coughing a lot.
He was coughing. Poor Saul. Yeah. So, guys, thank you so much. I hope it was fun. It was fun for us.
Actually, I like it because I was normally interview, and then it's very formal, and then I have to speak slowly, and then look in the camera and the video. This is a lot of fun because it's like friends talking, and I like it.
Yeah.
Because I'm so self-conscious. Otherwise, I get very self-conscious of my accent.
Always at these meetings, we have these amazing conversations. Just as speakers, I know you do. And it's like, God, I just wish the rest of the world could have heard this. That's fantastic.
They can. So an update since yesterday, We have had since we started here, we've had 1,400, about 2,000 people join in.
Yeah. Wow.
2,000 downloads.
That's great.
Yeah.
2,000 downloads. I shouldn't say that. Might be.
Download.
Yeah.
And I've been a great fan of Top Med Talk, and that's why we're so happy to have him here joining us at Spocky and at the Perioperative Medicine Summit.
Yeah. Thank you so much for having us. It's been great. And hopefully we'll have a chance to see you guys again. So thanks so much, and congratulations on a wonderful meeting.
Yeah.
Thank you.
Thanks.
Thank you.
Cheers.
Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com, and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.